So what's this all teach us? It teaches us that the nutritional guidelines are not working. And a little bit more about that, human diet has been different for 99% of our existence. And so when we go back to primal man with 2.5 million years ago, the Paleolithic period, basically we were opportunistic hunter-gatherers. So we ate whatever was available, but our diet was primarily an animal-based diet. Now, some of you may be vegetarians, and one thing is fairly clear, that we didn't start out as vegetarians, but we work with vegetarians, and so it's slightly a challenge because vegetarian diets are mainly plant-based and carbohydrate-based, but there's solutions for them as well. But what we have done since agriculture came 10,000 years ago, and then modern agriculture 250 years ago, we completely changed in a minute the way that we eat. So we went from this animal-based protein diet to a carbohydrate-based diet. And guess what? We're all sick. So there's a message there. And what we'd like to especially point to is the corn, grain, and wheat, the predominant, inexpensive, profitable, and refined carbohydrate that we're consuming in mass quantities now, and also sugar, of course. It's hard to change common sense thinking. People come in and talk to me about, well, we're supposed to eat a healthy diet. I think Alyssa Georgie gets credit for that healthy diet comment. I added to my slide. A balanced diet, eating in moderation, a low fat, a low carb, and these word fights are being thrown around. I don't even know what they mean anymore. And I've already talked about there's been this economic pressure to live and eat unhealthy. The healthcare industry, we're part of the problem. We're very reactive versus proactive. So we're spending billions of dollars treating the complications of obesity, and we're not treating the cause, the nutrition and the obesity itself. And I love this term, fat reform, and that's what I like to lecture about, to tell everybody that there's a problem with our nutrition. It's causing us to be unhealthy, and the cost of healthcare is escalating. And perhaps one of the ways to control healthcare costs is through lifestyle modification of our population. Makes sense to me. So the challenges are very easy to spell out on the slide, but to make these changes are very hard. And so we would want to redefine healthy nutrition. We want to promote wellness and longevity, to prevent disease and control the cost of healthcare, which I just talked about. And it turns out that we spend 2 to 3 times what other countries spend on the cost of healthcare. And the question is, what do we get in return? And we don't really get that much. And there's data that also shows that our rising rates of obesity is also contributing to the escalating cost of healthcare. And so lifestyle modification is a solution. Well, let's have a healthier population going into the healthcare system. And by quality of life, meaning that there's less visits to the doctor, we're not seeking medical treatment for illness. So the tools, how are we going to make these changes? The first tool is a lesson from the past, and then we're going to look at the science. And the science is really the physiology, the medicine of these medical conditions known as insulin resistance and inflammation. And so this is my road to discovery as a physician. We basically look back in time as if we were Sherlock Holmes, and we solved the case. It's elementary, my dear Watson. The problem is with the food. So it's insulin resistance that we're going to talk about that's going to provide clues and answers. And what's interesting, we've understood insulin resistance since the 1960s. But what is new is looking at food physiology. That is, how the macronutrients affect insulin metabolism. So, again, food physiology, how the macronutrients interact with their body. And the 3 primary macronutrients which we learned about are fat, protein, and carbohydrate. And we have medical conditions that we're going to talk about. And look, right up top, obesity and overweight. They are medical conditions. They're not lifestyle conditions. And it's a whole new way of thinking about this. And the conditions are insulin resistance, which is a progressive condition as we start gaining weight, adipose organ toxicity, inflammation, and energy storage disease. So this is the part, it's a little scientific. I'm going to try and zip through it. But it's important to understand this so you understand our metabolism. So we have an organ called the pancreas, and it produces insulin from the beta cells. What does insulin do? Insulin regulates energy. It decides what happens to the energy that we consume. It does regulate blood sugar, but we consider that a secondary purpose of it. Food energy that we consume triggers the production of insulin. And the beta cells, and this is important, is most sensitive to dietary carbohydrates. Why? Because dietary carbohydrates are a very simple form of energy. We call it the first energy source. It's very simple to burn, very simple to utilize. And think of carbohydrates as turning on the insulin switch. When we eat carbs, that insulin switch goes on. Dietary fat and protein have to be processed. They do not affect insulin like carbohydrate does. And it's a second energy source. Why does it work this way? Again, we look at the history of man and mammals. This is how it's worked for millions and millions of years. So we also have insulin receptors which respond to the message of insulin. And when insulin levels elevate, it says, hey, we have energy available in our bloodstream to absorb. And so the cells of our body, the muscles, the tissues, will absorb the energy circulating in the bloodstream. Now also the excess food energy will now be converted to fat and stored. And that happens when insulin level is high. And as you understand, our fat storage is this unlimited space where we can keep on growing and growing. Now there's another hormone called glucagon, and all I can say, when insulin goes up, glucagon goes down. As insulin rises, normally it'll tell us that we're full. And so we will suppress our appetite as our insulin levels go up in the normal state. Now when food's unavailable, reverse happens. So insulin drops, glucagon goes up, and we're now in a mode where we want to release energy from our storage. And again, dietary carbohydrate is the primary trigger for all this to happen. So now we overeat, and excess energy, especially carbohydrates, are now stored as body fat, and we gain weight and we get a larger body mass. The beta cells now need to produce more insulin because our body is getting bigger. And more insulin means more storage of body fat. Eventually, the insulin receptors become overstimulated as insulin levels rise, and they become strained. And the beta cells producing the insulin also become strained. And we get this loss of normal function. And the way to describe the beta cells, it's like a sticky gas pedal in a car, although you guys don't drive. But we're at a stoplight, and it turns green, and we push on the gas pedal, and nothing happens, so we push harder. And then all of a sudden, we release too much gas, and the car lunges forward, and then we realize, oh, we're going too fast, so we take the foot off the gas pedal. And this is like insulin releasing too fast. And it's now becoming, it's an abnormal function. And so what develops is what we call the vicious insulin resistance cycle. And I'll show you that actually what happens is that our fat cells starve the rest of our body, and it also makes us hungry. And so we gain weight, which leads to more insulin resistance and hunger. We produce more insulin, which causes us to gain weight. It's kind of a spiral of death. Another way to illustrate this is on the left is a normal functioning individual, and the green arrows represent the normal production of insulin from the pancreas going out to all the organs, including the fat cells. Now we develop insulin resistance, and our adipose tissue, or our fat tissue, has doubled in size. And we're insulin resistant. Now we're pumping out more insulin to keep up with the demand. We have resistance everywhere in our body. And what ends up happening is most of the energy that we're consuming is feeding the fat cells. And this is one explanation why people that have weight issues don't necessarily have a lot of energy, because all the energy is going to feed the fat cells. So I already said that insulin resistance drives hunger and appetite, and it's actually the fluctuating levels of insulin and blood sugar that will eventually pathologically stimulate our appetite. So normally our appetite is stimulated in the brain, but once we become insulin resistant, we lose that signal from the brain and the hypothalamus, and all we have left is our bellies that are swelling and painful. And you guys might even know the feeling over Thanksgiving, you eat until your belly's full, and we call that a food coma. And that's really an unhealthy way to eat and live. But the point there is that you're losing the signals from the brain when you become insulin resistant. Now there's many other hormones that affect our hunger and appetite in this whole pathway. And this is a complicated slide, but all I just want to say is that these hormones are some of the medicines that we use today to help treat insulin resistance, to control hunger and appetite, and their research over the next 10 years. And they're not appetite suppressants in the classic sense. They're smart hormonal drugs. So this is the other medical concept known as adipose organ toxicity. And simply stated, that means that our fat cells are toxic or inflammatory to our body. And it's the whole idea that our fat cells are an independent organ. So you have heart, lungs, and you have fat cells. The problem is that they're toxic. 95% of these substances called cytokines are being released by the fat cells, and they're inflammatory to the rest of the body. And this slide really illustrates that. So in the center of the world, we have the fat cells releasing all these inflammatory cytokines, leading to high blood pressure, heart disease, type 2 diabetes, metabolic syndromes, and things, and inflammation. And so this isn't really, insulin resistance is really a part of it, but the problem is fat cells and the storage of energy, and I love this term, energy storage disease, and it's inflammation that we're trying to treat nowadays. And this just further illustrates the relationship between the fat cells, and basically all the diseases in modern society are connected back to fat cells and inflammation. The metabolic syndrome is a particular condition of concern because if you meet these 4 criteria, you're at a greater risk for heart disease, and that is being overweight, having high cholesterol, high blood pressure, and prediabetes. So we watch for patients that have these conditions. So, as a doctor, how do we treat these patients? The first thing to understand is that this is a progressive condition where we start out overweight and we eventually develop type 2 diabetes. And the most important measurement in my office is to weigh a patient, measure their body fat. We want to review family histories, and we do blood work to measure markers of inflammation. But I just want to see how much my patients weigh. That's the best marker. That tells me, that gives me an overall picture of their health. And from this evaluation, though, we determine their degree of insulin resistance, and it's different for everybody, and that guides us in terms of how we treat patients. And the fun part here is that the food is the medicine. And I've been a doctor now for almost 20 years, and again in medical school they taught me how to prescribe medicine to treat this, that, and the other thing. Well, in this case, the food is the medicine, and we look to food and lifestyle modification to help our patients. And how do you think we fix this problem? We remove the fuel, and the primary fuel is? That's my man.
Yes.
So, yeah, good job. So, what do we do when we remove the dietary carbohydrates? Is we turn off the insulin switch. Stored energy will be released from adipose tissue. We lose weight, and it is basically anti-inflammatory by removing carbohydrates from our diet. It will control hunger and appetite for the same reasons. It's interesting, initially patients go through carbohydrate withdrawal when we do this, but we support them and tell them that they need to hang in there, that this withdrawal of carbohydrates will improve once the body learns to burn body fat for energy, and then all of a sudden energy starts to rise and they feel better. And they're actually not eating as much food because the food is controlling the fluctuation in the insulin levels. So again, less carbohydrate is consumed, and we're going to control the insulin levels and the hunger and appetite. So we talked about the other macronutrients